Thank you so much. I'm Lilian Kwamboka Nyaboga, an ophthalmic clinical officer cataract surgeon based at Kwale Eye Centre, which is in the coastal region. Today, I'm going to present on the findings of a study that we did at Kwale Eye Centre on patient pathway of screening and management of diabetic retinopathy. And we did this together with Dr. Helen Roberts, Nyawira Mwangi, and Dr. Jackie Ramke. A few acronyms that appear in these studies are DR for diabetic retinopathy, KEC for Kwale Eye Centre, PwD for persons with diabetes, and VTDR for vision-threatening diabetic retinopathy. This study, we had 4 objectives. The first was to describe the persons with disability presenting at Kwale Eye Centre by the social demographic characteristic of age, sex, and also looking at the DR status and visual acuity. Secondly, we summarized the DR treatment that was recommended against what they actually received. And we also calculated the proportion of people who attended their recommended annual reviews within the study period. We also calculated the incident rate of DR and VTDR. The study was a retrospective cohort at Kwale Eye Centre involving 949 adult patients who, from the routine data that was used. And the follow-up period was from 2016 to 2020, which was a follow-up of 43 months. At the facility that is Kwale Eye Centre, we have a Medbus system that is the database that the data is stored. So diabetic patients are yellow coded. So we use our inclusion criteria where we extracted data on follow-up, age, sex, presenting vision, DR status, treatment offered, and treatment received from the system of all the patients with diabetes who presented at the eye center. So these are some of the results. From the histogram, you can see the mean age of the patients who presented was 58, and which showed that the most hit group was the working age group. And looking further at the visual acuity at first presentation and the DR status at first presentation, we can see majority of the patient presented with normal vision of 6/18 and better. That is 58.6%. However, we also had those who presented with blindness, 11.1%, and severe visual impairment of 3.6%. Looking at the DR status of the patients, 63.5% presented with no DR, and we had those presenting with VTDR at 20%. Though we also had those ones that we could not determine the DR status at 11.2%. Further looking at the variables at first presentation, we look those with hypertensions, the hypertensive patients, we have almost 26% presenting with VTDR, and compared to the 16.6% of the non-hypertensives who presented with VTDR. Cataract was important comorbidity, ocular comorbidity. We're seeing 31.1% presenting with no view. So meaning that we are not able to determine the DR status. So cataract is an important eye condition that we really need to take care of, at the same time taking care of the diabetic patients regarding matters eyes. Looking at the visual acuity, we see those who presented with severe visual acuity, severe visual impairment, we have 74%, and blind patients also we had 70.1%, and mostly this was due to cataract. Regarding annual review attendance, the trend is quite wanting. See, the drop is, we are getting patients dropping out of follow-up. Those who are required at least one annual review, we have 46%, not even at 50%. And the trend keeps on dropping as those who required at least 2 with the visits within the study period, we had only 16. That is dropping from 46. Looking at those requiring 3, it automatically dropped off to only 7%. Treatment that was offered in the facility during the study period, we have the laser and the anti-VEGF. More people received the laser treatment, 57%, compared to 39% who received the anti-VEGF. And this is mostly because of the cost issues. Those who required anti-VEGF needed to pay upfront, unlike the laser treatment who were able to get even without the payment. Looking at our last objective, the fourth of the progression of no DR to DR, we saw we got 68 patients progressing from no DR to DR with an incident rate of 10.6, with incident at 10.6 and incident rate of 4 patients per 10,000 persons days. Among the 68 patients, we had 75% of them progressing to DR within the first 500 days. So it was an early progression. Progression from DR to VTDR, we got 7 patients out of the 29 patients progressing within the first 500 days. So giving an incident of 24% and the incident rate of 12 per 10,000 persons days. Among the patients who progress, 71% developed the VTDR within the first 300 days. So this is also an earlier progression rather than a later progression. Some of the factors that were associated with progression to VTDR, comorbidity with hypertension was significant, as you can see, having twice as higher hazards of the hypertensives progressing to VTDR compared to the non-hypertensives, and this was statistically significant. The key messages that we drew from this study was first, the low attendance of follow-up visits. This needs like a demand side of intervention to improve on the attendance. Secondly, looking at the poor integration of services at Kwale Eye Centre, there's a thought of improving these services and look forward of integrating other services into the eye institution. And also, we looked at the poor, we saw there was poor uptake of DR treatment, and mostly this was presented with the cost issues, in that most of the patients that go to the facility do not have insurance, in particular NHIF. So more intervention needs to be done in matters of encouraging patients to take NHIF when it comes to payment issues. And also the NHIF, for those who have NHIF, at least there should be a considerate of both the non-civil servants and the civil servants, because at the moment it's only taking care of DR treatment only for the civil servants. Only again, another thing we noted we can do is do targeted intervention of awareness creation, particularly more into diabetic eye disease. You can use the local measures that we have, the community health workers that are working within the eye facility. We have the CHUs that are working in the local facility. They can help in this awareness creation. And also it's important to look into the qualitative study, do more qualitative study, and get the barriers and diabetic services. Thank you so much.